I'm very excited to be here, and this will be a very different talk than the first two that you heard, but we're going to talk about identification and management of anxiety, depression, and stigma in patients with psoriasis. Here are my disclosures, actually one of which is relevant today, which is I did some work with UCB, which is responsible for a couple of my gray hairs that are on the top of my head, and as you might imagine, but all is well right now. So what we're going to talk about are the background, so identification and screening of patients with psychiatric comorbidity in the dermatology clinic, especially with psoriasis, management, and if I have a couple extra minutes, I'll talk about getting help, because there are certain questions that come up all the time that people want to know about, sort of picking my brain as a psychiatrist, how you can do things more efficiently in your dermatology clinic, because so much of what we see has a psychological impact. Okay, so we know that patients with psychopathology are underserved by dermatologists. They may be marginalized by dermatologists and their associates, and that may not be true for the majority of the people in this room, as we know, because so many of our patients with psoriasis do live with psychiatric comorbidity, and we did make the decision to treat patients with psoriasis. However, many of our colleagues and many of us in this room also may feel undertrained, undereducated in treating psychopathology, uninterested, and especially in practicing in the United States, we are extremely limited by time, or maybe uncomfortable or anxious about asking certain questions. So this is sort of the perfect setup for a poor patient experience. So we know, as I sort of alluded to before, that psychological factors may be involved in 1/3 of the cases that we see in dermatology clinics. We know depression, anxiety, suicidal ideation, and behaviors are seen pretty substantially in patients with skin disease compared to what we see in the control populations. This is one of the first studies that Dr. Gelfand's group did back in 2010, but they were looking at psoriasis patients with anxiety, depression, and suicidality, and they found elevated levels in all those groups. So since that time, the association between depression and psoriasis has been confirmed multiple times over, then the largest study being the 50,000 women's nurse health study. And then depending on what literature you're looking at and the way the screening was done, estimates of prevalence of major depressive disorder in patients with psoriasis are anywhere between 9% and 55%, which is sort of a ridiculous statistic, but it's out there, right? So, but the role is very nuanced, and it may be different in different patients. Depression may be a triggering factor for psoriasis. It may be an exacerbating factor. It may be a consequence, and sometimes these roles are reversed as well. But the interplay between depression and psoriasis is very much intertwined. We know that increasingly severe psoriasis is associated with an increased risk of depression, and there are many known associations with decreased quality of life, which I will not belabor today. The story with suicide and psoriasis is a little bit more complicated. It has not been found to be consistently associated, but part of that has to do with the way that studies are analyzed. But this is sort of a very concerning thing. Obviously, suicidality is a very concerning thing to have in any of your patients, but it's especially concerning in a psoriasis patient who doesn't have objectively severe psoriasis. And we see this with patients with lots of inflammatory skin diseases as well. We know that the severity of psoriasis does not always correlate with the emotional toll. So you may see someone who has almost clear skin, and they may be having thoughts about this as well. But we know, looking at the data, that it's younger patients with more severe psoriasis have the increased risk of suicidality. There are obviously exceptions to that rule. We know that with increased psoriasis-related stressors and decreased quality of life can be associated with suicidality. The most recent systematic reviews, which are actually not that recent anymore, they're from 2017, did find some conflicting data. It really had to do with the way that the trials that they were looking at were screened in the inclusion criteria. And the trials that were a little bit more rigorous in their inclusion criteria, looking at pure cohort studies, did not find that an association between suicidality and psoriasis existed, but it was a question whether or not this study was powered enough. It was like 4 or 5 trials. The larger study that was published by Singh et al. In our Blue Journal did find the association was there between psoriasis, suicidal thoughts, suicidal behaviors, and completed suicide. So the jury is still out, but it's something that we should all be mindful of. So anecdotally, we all sort of hear it from our patients and we hear it from our colleagues, and we sort of may intrinsically feel this way as well, that stress and psoriasis are intrinsically linked. And that association has been like sort of colloquially well established, but the true biological data is limited. I just thought that this was an interesting study to bring to everyone's attention if you weren't familiar with it, or just to be reminded. It was an interesting study looking at HPA, hypothalamic pituitary adrenal axis dysfunction, using the PASI, the DLQI, the PHQ-9, and life events, and they were able to show an association between bedtime salivary cortisol levels being elevated and worse scores on the PASI. Okay, and again, I don't want to belabor health-related quality of life. I think it's probably common knowledge in this room that psoriasis is very much associated with poor quality of life, and it has comparable decreases in health-related quality of life to diseases that the general population and maybe some of our colleagues in medicine may think are more severe, like COPD, like cancer, heart disease, and diabetes. And stigmatization, I think, is one that's interesting to think about. It's one, there's a lot of psychological impact here. A lot of patients living with psoriasis have fear of the negative evaluation from their peers, from their friends, from their family, and that stigmatization can be internal and it can be external. So if you think about external stigmatization, it's really the awareness of social disapproval, discrediting, or devaluation based on the sort of the attributes or the physical stigmata of psoriasis in the body. However, that can become internalized, and that becomes much more problematic, I think. With internal stigma, the person living with psoriasis or whatever cutaneous disease endorses those stereotypes about that attribute, about the stigma, and things that are sort of socially thought as discreditable, and then applies those to him or herself and sort of internalizes those. And that can be very problematic in terms of their psychological functioning. There's obviously, in the general population, maybe less so now because of the good work of a lot of the biologics and sort of destigmatizing psoriasis for the general public and putting advertisements out on television and in magazines and the print media and on social media as well, that people are a little bit more familiar with psoriasis, but there are still a lot of misperceptions about contagion and hygiene that are still associated with psoriasis. And there, we know that we have interesting data showing implicit bias and disgust reactions of others who are viewing patients with psoriasis and the chronic cutaneous stigmata. So it's not a stretch to see how people living with psoriasis who have internalized this stigma feel socially rejected, may feel anxiety about that, may have social anxiety tendencies, and may even develop personality styles that may be avoidant. And I do want to talk a little bit about body image as well, because it is related to the threat of stigmatization. You know, body image dissatisfaction is very common in the general public, right? It's so common that there's a term called normative discontent that was coined in the 1980s, and the psychology literature is really referring initially to women and the way that they feel about their bodies. It's so common for women to feel uncomfortable in their own skin that it has been called normative discontent. This data has since been replicated in the male population as well. But thinking about this in patients with psoriasis, this may cross into the line of body image disorder. And I'll show you why. There was this big study that probably everybody was aware of that came out, I guess it's almost more than a year ago now, in the British Journal, looking at body dysmorphic disorder and body dysmorphic disorder symptoms in common inflammatory conditions of the skin. And I was pretty blown away about the extent of this study and the scope and the data, what they found. But looking specifically at patients with psoriasis, people living with psoriasis at more than 6 times increased chance of having BDD symptoms. And these symptoms were related to lower age, female sex, psychological stress, and feelings of stigmatization. So sort of related to what I was saying before about the patient with suicidality who may have clear or near clear skin. When I think when the general public thinks about people with body dysmorphic disorder, and actually some of my colleagues who think about people with body dysmorphic disorder, they don't realize that these people are not truly dysmorphic. These are people who look very attractive, or have features that are almost imperceptible to the general population, and they are going crazy over them. They're completely obsessed, they're depressed, and they can be very suicidal. So this could be your psoriasis patient who has that coin-sized lesion on the back of their elbow and otherwise clear skin, but is crippled with anxiety, depression, and potentially suicidality. So how do we identify these patients in the clinic, right? So for those of you, you probably know depression when you see it when it's very severe, but by, beyond using your kind of spidey sense, here's some basic clues from, psychology and psychiatry 101. Thinking about depression on top: poor eye contact, slow movements, slower impoverished speech, poor posture, right? People with anxiety type symptoms are going to be on edge. They're going to be worried about things. You're going to have to constantly give them reassurance, and it can be extremely annoying to deal with someone who has anxiety. So if you feel like the pull to get out of the room or to tell somebody to stop, this visit is over, you're probably dealing with someone with anxiety who doesn't have a lot of control over it. And this hyperfixation, perseveration, obsession can be anxiety symptoms as well, but they can also trend towards the OCD, BDD type symptoms. So sort of tune into your own personal experience when you're dealing with a patient, whether that's a patient with psoriasis or anyone else, and that can give you a lot of clue as to what you may be dealing with. And it can take it from the sphere of annoyance into something that's more intellectually interesting, and you'll be able to help them at a better level. So what do I do for screening? I try to keep it really practical because I know that we are all limited by time. But there's a couple different screening questionnaires that can be very helpful to you. You can memorize them, or you can just have them as part of your intake. But here's the PHQ-2, which is very easy to do. It asks you about the last 2 weeks, how often you have been bothered by little interest or pleasure or feeling down. And the magic number here is 3, okay? So the score is 3 or greater, major depressive disorder is likely, and you can either take that information and you can, if you have a very good relationship with a psychiatrist or a psychologist, and you want to think about referral at that point, you could do that. And we will talk about some of the other things you can do in the office with patients. And you can take the PHQ-2 and extend it to the PHQ-9 if people screen positive. The GAD-2, also a good psychological screener that's very efficient to do, looking at anxiety-like symptoms. And you're basically asking people if they're feeling nervous, anxious, or on edge, or not being able to stop or control worrying. Again, magic number being 3. This is from the primary care settings, but I'm not sure if you can read the numbers from back there, but pretty good sensitivity for generalized anxiety disorder, and for any anxiety disorder, pretty good specificity of 88%. And then I don't think this is something we generally talk about much with psoriasis patients, but BDD is one of my sort of passion projects as someone who practices a lot of cosmetic dermatology, and trying to get people in the field of cosmetic dermatology to think about their patients in this way. But seeing what we saw with that study coming from the British Journal, we probably have to be thinking about body dysmorphic disorder with our psoriasis patients as well. So this is a single question that you can ask from the BDDQ dermatology version, body dysmorphic disorder questionnaire dermatology version. This is actually based on the DSM-4 criteria, not the DSM-5 criteria, but I still think that it's good even though it hasn't been updated. Are you very concerned about the appearance of some part of your body which you consider especially unattractive? If someone comes in head to toe psoriasis, you don't really have to ask this question. But if someone has almost clear skin, they will answer this question probably in the affirmative. Most patients will be like, what are you talking about? This is such a weird question, right? And that's actually good information as well, that you can just move on. But this question in itself, 100% sensitivity, 93% specificity, BDD, okay? In that one screening question, if they say no to it, your screener is over, okay? But I wouldn't want you to miss BDD in this population. I think that's always been something that I was wondering about since I was a medical student. Who were these psoriasis patients who people talked about being so depressed, so anxious, but almost clear skin? And I was wondering if we were dealing with BDD patients the whole time and no one was asking the right questions. So I don't want you to miss these because the mental health comorbidity with BDD is astronomical, and the dangers to yourself and your personal life is astronomical. These patients are highly suicidal, 40 times the rate of the general population in suicidality. highly litigious, they can be violent. These are patients that you want to make sure you don't miss. Okay, and thinking about management, what can you do? So at minimum, we should be able to sort of talk about what the management options are. And I was talking with Dr. Gelfand before I did this talk. Most people don't want to hear about this, so if you want to tune off, this is okay. But I have a lot of difficulty with some of my colleagues in generating interest in talking about some of the psychological comorbidities. But you should be able to talk about there's two different modalities of treatment you can get for mental health. There's medication management or psychopharmacology, and there's talk therapy or psychotherapy. Okay. So thinking about psychopharmacology or the medications, the easiest, the low-hanging fruit here is the selective serotonin reuptake inhibitors, the SSRIs. Been on the market for a long time. We know a lot about them. They're really good for anxiety, depression. Actually, I wouldn't say they're really good. They're okay. Okay, we're not really good at anything that in terms of treating with psychopharmacology and psychiatry right now, but they're pretty good for anxiety, depression, and at high doses, they're really good for OCD and BDD. That's a type of BDD. But here's the top things to know about SSRIs. I think if you knew these things, you could probably start prescribing them with confidence, because everybody in this room prescribes medications that are a lot more difficult to prescribe than SSRIs, and we do it every day as biologics and medications like cyclosporin and methotrexate. If you feel comfortable with that stuff, should be easy. Onset to SSRIs being effective, it takes about 4 to 6 weeks, so it's slow going. But you want to start low, and you want to go slow. So you look at the recommend doses, take them down by half, and increase the dose every 2 weeks if there are no side effects. Increasing it more quickly will not make them work more quickly, but it will give more side effects. Number 3, at 6 weeks, or if someone has intolerance, you can switch to another SSRI. If there's a partial response, you can slowly increase the dose to the maximum dose, with the exception of citalopram, and I'll talk to you about that. There is a withdrawal syndrome if these are stopped abruptly, especially with Paxil or paroxetine. And if someone does have a response, you want to continue for at least 6 months after reaching that response before deciding to titrate people off. There is a black box warning for suicidality in patients who are under the age of 25. So you have to ask questions about suicidality if you're going to start these medications. And the most common side effects are GI upset, weight changes, and sexual dysfunction. Every single one of these medications has the potential for sexual dysfunction, so you have to talk to your patients about that. And finally, citalopram in isolation has to be under the dose of 40 because you put people at risk of having cardiac arrhythmias. This is a little chart that actually comes from our literature. This comes from the Blue Journal from a couple years ago, which is a nice chart looking at SSRIs. And the words are too small here, but there's 3 take-home points that I think they're worth knowing. And maybe worth taking a picture of this from the journal article or reading the journal article if you're interested in prescribing these medications. But the 3 things I want you to know, again, all have sexual side effects, okay? Fluoxetine or Prozac, there is no discontinuation syndrome, but Paxil does have that, so you don't want to abruptly stop it. And then citalopram, a dangerous medication to be on at dosages over 40 milligrams. So I think among this list, fluoxetine, sertraline, and escitalopram are very easy drugs to use. And in the United States, where it's very difficult to get people into a treatment with a psychiatrist or sometimes even with a general practitioner, those are very easy medications to do drug trials of on your own, in your own clinic if you want to do so. And just wrapping up, thinking about psychotherapy or psychoeducation. Psychoeducation is your first step, and that's basically just telling people it's okay to understand that these things may be going on with you if you have psoriasis. Depression, anxiety, suicidality, poor quality of life have all been associated with your condition and may impact comorbidities in the progression of your psoriasis. Self-help tools are out there, which can be somewhat helpful if used in regularity, but they're not particularly helpful for moderate to severe depression, and sometimes not even for mild depression. And these are things like exercise, socializing, relaxation techniques, which are widely available online for free on platforms like YouTube, apps like Insight Timer, which is free to download as well. And then if you want to talk to people about what talk therapy looks like, there are many different types of it, and I find it destigmatizing to just at least be able to be somewhat familiar with what happens. CBT, or cognitive behavioral therapy, basically the process of working with a therapist to identify and reshape your thoughts and behaviors that contribute to your mood. Helps people to sort of alter their dysfunctional thought patterns, their cognitive piece, or their actions, the behavioral piece that lead to psychological distress. Okay? These are as effective as antidepressants for mild to moderate depression, and these have a couple of distinct advantages. They're time-limited, they're long-lasting, okay? So time-limited, you're only in therapy for a couple months. These are long-lasting skills that you will have with you after your therapy is over, unlike psychopharmacology, which you would titrate off, and then you will be without those rewards after they're gone. But combination treatment may be best with talk therapy and medications. I think I'm out of time, so I'll probably wrap up here. Thanks.
So that was really a great talk, Evan. A lot of practical information in there. I actually learned a lot. You know, one phenotype I see in my practice, I realize from time to time, which was probably BDD, is people come in and they're convinced they have psoriasis. And they don't. They have nothing. Their skin's completely normal. And they're often irate when I explain, good news, you don't have psoriasis. And I realize that's my own ignorance of what's probably going on, because the patient probably has some form of BDD, is my guess.
Or it's a different flavor of a delusional disorder, right?
Yeah, maybe. Right.
It's like
maybe one question for Dr. Rieder, Bruce?
More of a practical question, Evan. When you're in your chart and you're treating psoriasis, do you put a separate impression for a diagnosis of a psychiatric illness, or do you put the prescription for SSRI under the psoriasis impression?
Yeah, that's a good question. And if you think about it if you're really be practical about it from a reimbursement perspective, you're going to get a higher level of billing if you have a separate diagnosis. But I think I probably would. I would diagnose psoriasis, and I would diagnose major depressive disorder, mild or whatever.
Okay, great. Maybe one more question. Yeah, please.
From the work of Elise Klein from Manchester, there is evidence that depression and psoriasis is associated with neuroinflammation. And my question to you is how to look to depression in psoriasis in the perspective of neuroinflammation. That is, when this evidence really is practically important, it's important that we treat patients with psoriasis maximally with anti-inflammatory treatments in order to improve also the neuroinflammation component. And the other thing is that when we are able to treat the inflammatory aspects in psoriasis well, the perspective of the treatment of the depression could also be much more with medication in order to intervene with the depression. Can you answer the question indeed in the perspective of neuroinflammation?
Yeah, and it's a good question. I think that's an active area of research, and I think it depends on what type of depression you're thinking about. I always tell people when we talk about the term, sort of like when we talk about the term eczema, it's a wastebasket term. There's many different ways to get to eczema. You get there for dry skin, you get there from a contact allergen that may be an irritant or an allergen. You may get there because you have a genetic predisposition. The same thing sort of applies to depression, right? There's many different ways to get to depression, and there are neuroinflammatory theories of depression which may coalesce with the depression that goes along with psoriasis, but I don't think that's a universal phenomenon that we see with psoriasis patients because there's so many confounding factors that we haven't completely I'm sorry, we can talk about this offline.
That was great.
It's
Thank
a
you so
big
much,
question.
You know, it's such an important topic in our field. You know, many of our medications carry warnings for mood disorders, whether that's really from drug or not, is debatable, I think. And this issue comes up a lot in our practices. So thank you so much, Evan. Appreciate that.